grateful and honored for the invitation. I am really appreciative of this opportunity. And as you can see, I'm particularly grateful for the title, which I did not choose. This title gives me enormous flexibility to talk about almost anything. And what I am going to try to do is to tell you a story that you have never heard before. So, my disclosures. This is Paul Wood. If you don't know, Paul Wood was the master clinical cardiologist in the European theater in the 1950s. He had a distinguished career. For all practical purposes, almost everything you know about the cardiac physical examination, he described in his famous textbook. He put clinical cardiology on the world map. And so I went and tried to look at some of his papers, and I found this really interesting one. This is from what used to be called the British Heart Journal from 1940. Second volume. It was just a child in 1940. This is the first actual description that digitalis had a positive inotropic effect. This was not an animal model. This was done in patients. It was done using circulation time as a primary measure. Can you imagine the incredible amount of observational power and meticulous bedside examination that would have allowed this kind of study to have occurred? That price, that precious gift, is actually still with us in each and every one of us. So now, I am going to tell you a story. When I first started in cardiology, and sadly it was before the 1980s, this was what heart failure looked like. Typically, a middle-aged man, history of hypertension, smoking, hypercholesterolemia, coronary artery disease, frequently a history of a myocardial infarction. And that resulted in a certain syndrome of heart failure that we call heart failure with a reduced ejection fraction. We think we understand this disease. We understand its triggers. We understand its evolution. We understand the role of neurohormonal activation and left ventricular remodeling. But I don't want to talk about this disease because you always hear people talk about heart failure and a reduced ejection fraction. I want to talk about the face of heart failure today. This is what heart failure looks like today. What it looks like is a patient who is obese, who's diabetic, who has a metabolic syndrome. It is characterized by systemic inflammation. It is particularly characterized by the combination of atrial fibrillation and heart failure with a preserved ejection fraction. This syndrome has reached epidemic proportions. It has reached epidemic proportions wherever there is an obesity epidemic. and there is an obesity epidemic in most of the world. This is the most common cause of heart failure in the United States. So what I want to do is talk about a syndrome that everyone sort of thinks they understand, but I think deserves a very, very special story. And I want to begin by asking a very, very simple question. What is this disease? What does it consist of? Why does it happen? And why does it happen to these people? So I'm going to try to identify the major source of this disease and this epidemic. And it focuses on a part of the heart that no one talks about. It's called the epicardium. You might say, no one talks about the epicardium. It's just an epithelial layer that tells the heart where to stop. It surrounds the heart. It's sort of a covering, reasonably dormant, inert, rather bland and uninteresting. And it is, in fact, designed to be bland and uninteresting in most healthy adults. But it didn't start that way. The epicardium is a major source of cardiac morphogenesis. So much of the structures of our hearts are derived from cells that migrate from the epicardium during fetal development. The epicardium during fetal development is an extraordinarily active place. And at the end of the development of the heart, the epicardium becomes quiet. The epicardium becomes dormant. And in fact, the epicardium assumes a nurturing role. Whatever is left of the epicardium after fetal development has some of the features of brown adipose tissue. It secretes adiponectin, it combusts fatty acids, it nourishes the underlying myocardium. Remember, when you look at the epicardium and you look at the myocardium, there's no separation between the two. They share an unobstructed microcirculation. They're essentially one organ with no physical barrier. And the epicardium is just an epithelial layer with a few adipocytes, brown adipose tissue, and that's what a healthy epicardium looks like. But if the epicardium becomes activated during adulthood, if it expands, if it becomes inflamed, then the adipocytes in the epicardium assume the features of white adipose tissue. They don't combust fatty acids, they release them. They do not nurture the heart, they release pro-inflammatory adipocytokines that injure the heart. And because there is not a physical barrier, anything that the epicardium produces in disease or even in healthy people is transmitted to the underlying adjoining myocardium. And that is the most important thing I want you to remember. Because everyone ignores the epicardium, and I hope that after today, you'll never ignore it again. So, what makes the epicardium biologically active? In everyone in this room, it's dormant, quiescent, nurturing, almost maternal. And yet, it wakes up, becomes biologically active, becomes biologically aggressive in certain disease states. Two main domains of disease states activate epicardial adipose tissue. The first are metabolic diseases: obesity, diabetes, metabolic syndrome, others as well. Second, nearly every single disease that we characteristically refer to as a systemic inflammatory disorder activates the epicardium. So, whether we're talking about chronic inflammation of the joints, chronic inflammation of the skin, chronic inflammation of the gastrointestinal tract or the kidneys, or chronic infections, all of these activate the epicardium, activate the adipocytes in the epicardium, and turn those adipocytes from nurturing cells into pro-inflammatory cells. And the essence of it is that the reason that all of these disorders injure the heart is because they injure the epicardium. They activate its biology, and the epicardium, specifically epicardial adipose tissue, becomes the transducer of the effects of systemic disorders onto the myocardium, whether they are metabolic disorders or they're systemic inflammatory disorders. So the epicardium surrounds the heart, nurtures the heart, but it wakes up in a whole host of systemic disorders. And when it does, it transmits to the myocardium a whole host of adverse biological mediators. Some of them are adipocytokines. Some of them are migrating mesenchymal cells. There are almost certainly other factors which have not been well identified. And these cause a variety of stresses: nitrosative stress, inflammation, microcirculatory dysfunction, phosphorylation of titin, fibrosis, all as a mechanism by which the epicardium, when it's activated, transmits its dysfunction to the underlying myocardium. Now, if the epicardial inflammation surrounds the left atrium, then you get an atrial myopathy, and the way that we see that clinically, most of the time, is on the electrocardiogram. Patients present with atrial fibrillation, and everyone says, oh, you have atrial fibrillation, which of course is a biomarker of an underlying atrial myopathy commonly related to epicardial adipose tissue inflammation. If the epicardial adipose tissue surrounds the left ventricle, then the left ventricle is impaired in its ability to accommodate blood. it becomes stiff. There is decreased distensibility. And that is the hallmark of heart failure with a preserved ejection fraction. So the same process, when it affects the left atrium, produces atrial fibrillation. When it affects the left ventricle, produces heart failure with a preserved ejection fraction. And these coexist to an incredibly convergent degree in the community of middle-aged to older women who are obese, have metabolic diseases, and have chronic systemic inflammatory disorders. It has been estimated that most obese women who have atrial fibrillation have underlying heart failure with a preserved ejection fraction if you only were to catheterize all of them. But you should not do that. But if you did, you would find that their filling pressures were significantly increased. And if you see someone who is at risk and they have a diagnosis of heart failure with a preserved ejection fraction, and if their electrocardiogram shows sinus rhythm, you just happen to have caught them at a good time. Because if you do serial and prolonged ECG monitoring, almost all of them have atrial fibrillation. So, atrial fibrillation, heart failure, preserved ejection fraction, in patients with metabolic and inflammatory diseases are part and parcel of the same genesis. It is epicardial adipose tissue expansion and inflammation. Now, that's why if you look at the epidemiology of obesity, diabetes, metabolic syndrome, rheumatoid arthritis, inflammatory bowel disease, chronic kidney disease, there is a 3 to 5-fold increase incidence of atrial fibrillation and a similar marked increase in heart failure with a preserved ejection fraction. All of these diseases are characterized by an increase in both an atrial myopathy and a ventricular myopathy. But one disorder is the major accelerant. One disorder makes everything worse, and that's obesity. Now, many of you may know that, of course, we have an obesity epidemic. It is getting worse. But obesity makes almost every chronic metabolic and systemic inflammatory disease worse. So it doesn't just make diabetes worse, but it makes rheumatoid arthritis worse. It makes inflammatory bowel disease worse. It makes chronic HIV infection worse. Obesity is an accelerant. It's a metabolic accelerant, and it's an inflammatory accelerant. So the most of the responses to drug therapy for rheumatoid arthritis, for psoriasis, for inflammatory bowel disease are impaired. Their efficacy is impaired if people are obese. The risk of heart failure in rheumatoid arthritis is about 5-fold in the general population. It's the same as it is for all the other diseases here. And the heart failure syndrome is not primarily ischemic heart disease. It's heart failure with a preserved ejection fraction and it's atrial fibrillation. So now you have to ask a really interesting question. Why does obesity do this? I understand that it's a metabolic stress. I understand it's an inflammatory stress. I understand that it does all of the, it exacerbates all of the biological processes that will drive dysmetabolism and inflammation. But it also is a major accelerant of epicardial adipose tissue expansion and inflammation. If someone has obesity and diabetes, there is an additive effect on epicardial adipose tissue volume. That's true when obesity is added to almost any of the other diseases that I spoke about. Obesity is a major driver of heart failure, whether patients have heart failure with a reduced ejection fraction or heart failure with a preserved ejection fraction. But it's really a driver of heart failure with a preserved ejection fraction. 75 to 85% of patients with heart failure and a preserved ejection fraction are overweight or obese. And if they lose weight, they have less heart failure. If they gain weight, they have more heart failure. So it's really interesting. The question is, why is heart failure with a preserved ejection fraction so common? In fact, there are those who say that almost every obese person who has exertional dyspnea has exertional dyspnea not because they are carrying a big load, but because they have heart failure. When you catheterize them, their filling pressures are high. Their cardiac outputs may be normal, their cardiac outputs may be elevated, but their filling pressures are not normal. There are actually two types of heart failure with a normal ejection fraction in obese people. And I want to talk about both of them because they're both really common and they're both really important. I'm going to call one of them hypervolemic stress. I would like to call it hypervolemic heart failure, but frequently the syndrome, full syndrome of heart failure, just doesn't manifest itself. And I'm going to call the second syndrome obesity-related heart failure with a preserved ejection fraction. I want to say at the outset that hypervolemic heart failure is a disorder of plasma volume expansion. Obesity-related heart failure with a preserved ejection fraction is an inflammatory disorder. So this is a side-by-side comparison. I'm going to take you through this because it is so easy for you to distinguish between these two at the bedside. So first, both are obese. Two, both have normal ejection fractions. Three, they both have increased filling pressures, and the echocardiogram will be read as having diastolic dysfunction, which neither syndrome has. There are increased filling pressures with a preserved ejection fraction. Here's the biggest difference between the two. The biggest difference is that hypervolemic stress, it does not have the activation of inflammatory mediators. No matter how you measure inflammation, whether you measure it with C-reactive protein, interleukins, any adipocytokine, they're not elevated in the patients with hypervolemic heart failure. Their adipose tissue is actually normal or thin. This is in marked contrast to the individuals who have obesity-related heart failure with a preserved ejection fraction. Their inflammatory mediators are markedly increased. C-reactive protein markedly increased. Every single cytokine that you can measure markedly increased. And since this is a Paul Wood lecture, if you hang up a SED rate, it is markedly increased. Happen to like SED rates a lot. These individuals have thickened epicardial adipose tissue, expanded, inflamed, and as a result, those with hypervolemic heart failure have a very low incidence of atrial fibrillation, whereas those with thickened epicardial adipose tissue markedly increase 60-70% or even more. Those on the left are volume expanded, and because their volume expanded, their volumes are increased, cardiac volumes are increased, their natriuretic peptides are increased, maybe not as much as one might think because they are obese, but this is very different than what you see on the right. On the right, the hearts are enlarged, but they're only modestly enlarged. And the natriuretic peptides are not markedly increased. Sometimes they're actually within the normal range, even though the patients have pulmonary wedge pressures and left ventricular and diastolic pressures, which are markedly increased. And just to add to the inflammation hypothesis, if you look at the kidney, you see a major difference. The hypervolemic patients have GFRs that are normal or even increased, whereas those who have obesity-related heart failure with a preserved ejection fraction have impaired glomerular function. So if you see an obese individual who is short of breath, and their ejection fraction is in the normal range, I want you to look at two things. I want you to look at their electrocardiogram, and I want you to look at their renal function. If they're in sinus rhythm and their renal function is normal, they probably have the syndrome on the left. If they're in atrial fibrillation and their renal function is impaired, and especially if their hearts are not markedly dilated, they have the syndrome on the right. Now, both of these syndromes are symptomatic. Both of these syndromes are serious. And both of these syndromes are incredibly underdiagnosed in the clinical community. Most people who have hypervolemic stress are told by their physicians, "You are fat. Of course you're short of breath. If you could only lose 70 kilos, you would feel much better." Actually, what the physician is saying is, if you lost 70 kilos, I would feel much better. But that shortness of breath is a hypervolemic state. But it's a reasonably easy hypervolemic state to pick up because natriuretic peptides are typically a bit elevated. The really hard diagnosis is the one on the right, because the natriuretic peptides are not markedly elevated. The ejection fraction is in the normal range. The diastolic filling parameters on echo are very non-specific and are frequently attributed to concomitant hypertension. So remember, atrial fibrillation, impaired renal function, signifies the syndrome on the right. If both are absent, we're talking about the syndrome on the left. Now, why is glomerular function impaired? It's a really good question. Two theories. First, is that the same inflammation that occurs in the epicardium, in the epicardial fat, occurs in the perirenal fat. And that's transmitted to the kidney to impair glomerular function. The second is that the adipocytes make a substance which is nephrotoxic. And we'll talk about that second syndrome, that second hypothesis, in just a moment. So, this is what you see every day. Actually, most cardiologists probably don't see these patients. These patients are primarily seen in primary care. And they are told that they are getting old, and shortness of breath goes along with getting old and being fat. Their symptoms are not taken seriously, but they have a very serious disease. So, what is really driving this? Why is obesity the accelerant? Why does the adipose tissue become inflamed and expands? Well, one possibility is that adipocytes are making something which is toxic. Now, adipocytes are incredible hormonal factors. And the more you have, the more they make. I'm going to mention two substances, two mediators that are made by adipocytes, which I think are important regardless of whether we're talking about the syndrome on the left or the syndrome on the right. One is aldosterone. Second is neprilysin. As people body mass index increases, circulating levels of aldosterone increase. As body mass increases, neprilysin increases. Why? Adipocytes make aldosterone. They make neprilysin. And in fact, it has been estimated that most of the aldosterone in an obese individual is coming from adipocytes and not from the adrenal gland. So these are important because, of course, if you have more aldosterone and you have more neprilysin, which means you have less natriuretic peptides, they will conspire together to cause sodium retention, plasma volume expansion, and cause hypervolemic stress. And that will be true whether we're talking about the syndrome on the left or the syndrome on the right. So, sodium retention and hypervolemia is a feature of most obese individuals, and it is related to the mediators that adipocytes make. Let me show you probably the most interesting data that supports this from a clinical trial. This is a trial of a mineralocorticoid receptor antagonist, eplerenone, blocks the actions of aldosterone. This is a trial called the EMPhASIS trial. It was a trial done of eplerenone versus placebo in about 3,000 patients, who had heart failure and a reduced ejection fraction. You might say, I'm not talking about heart failure with a reduced ejection fraction, but I am talking about obesity. This is the overall effect of eplerenone in the trial. Eplerenone produced a 37% reduction in risk of a serious event, specifically in this case, death, cardiovascular death or hospitalization for heart failure. And the investigators went back and they made one measurement. The measurement that they made was waist circumference. Now let me say that you can measure obesity in a variety of different ways. You can certainly weigh patients, you can measure body mass index, you can estimate visceral adiposity by just a tape measure, waist circumference. So here is the breakdown in this trial in individuals who were non-obese. Now notice that eplerenone is having an effect compared with placebo in non-obese individuals, but it's a small effect. This is the effect of eplerenone in patients who were obese. There's an over 50% reduction in the risk of the primary endpoint with eplerenone in patients who had visceral adiposity compared to those who didn't have visceral adiposity. And what is really interesting is, of course, no aldosterones were measured in this trial, but this kind of pattern, a difference between the response in obese versus non-obese individuals, especially when it comes to waist circumference, has been observed in other trials as well. So obesity promotes hypervolemia because adipocytes secrete aldosterone and epilysine. Interestingly, both natriuretic peptides and aldosterone feed back onto the epicardial adipose tissue to transform its biology. So aldosterone itself causes epicardial adipose tissue to expand and become inflamed. Patients with primary hyperaldosteronism have thickened epicardial adipose tissue. It promotes a transformation of the biology from a nurturing biology to a pro-inflammatory biology, and it probably contributes to the cardiac fibrosis, which is so characteristically seen in experimental models of aldosterone excess. It's not just the increase in aldosterone, it's the decrease, it's the loss of the counteracting effects of natriuretic peptides. Normally, natriuretic peptides would oppose the action of aldosterone, but that can't happen if you have increased levels and increased activity of neprilysin. So both of these working together are not just increased in obese individuals, they actually can transform the epicardium from a nurturing to a pro-inflammatory state. But I want to really hone down on what it is that the epicardium makes that hurts the heart. So there's a number of possible adipocytokines. This is just a partial list, please. It really is just a partial list. There are dozens of adipocytokines. Then they're all pro-inflammatory. They all can cause microvascular dysfunction and destruction. They can all be pro-fibrotic. They all can cause molecular changes in the heart, and in its proteins to make the heart stiff. But the one that I've been most excited about is leptin. Now, leptin was originally discovered as a satiety factor, but it is a fascinating molecule. Of course, the more obese people are, the higher their circulating levels of leptin. Every single disorder on this slide, diabetes, metabolic syndrome, rheumatoid arthritis, psoriasis, inflammatory bowel disease, all associated with markedly increased levels of leptin. Leptin probably doesn't cause the epicardium to become inflamed, but increased leptin is what happens when the epicardium becomes inflamed, and it secretes pro-inflammatory mediators, because leptin